scenario of cold injuries and frostbite. A call has been received from A&E with a patient previous history of falling while hiking and is now complaining of the numbness of the hand with discoloration. You review the patient. He is a middle-aged gentleman, right hand dominant, denies any pain, but his left hand is discolored after he had to stay in a temperature below 0 degrees centigrade for 24 hours. The left hand is discolored, mottled, and has reduced sensations. He is unable to flex or extend the fingers. The core body temperature is 34. Vital signs are normal. The body is immediately rewarmed, and warm oral and IV fluids are given to the patient. Tetanus prophylaxis was given, and the affected hand was placed in a circulating warm water for 30 minutes. Within 24 hours, blister developed on the digits, and he had significant pain. The hand continued to exhibit diminished sensations, and digits appeared ischemic. The entire skin of the hand was now covered with aloe vera ointment and dressing with a sterile soft dressing. An X-ray block was performed due to the significant pain to provide a sympathetic block to aid in pain control. The patient was admitted in the hospital, and 24 hours after the admission, the bone scan was performed, which shows no activity in the finger or the distal palm. An arteriogram of the extremity reveals no blood flow below the wrist. So what are differential diagnoses here? It can be either acute frostbite, Raynaud disease or syndrome, a vascular disease, or a neurogenic disease. Here, in our case, it seems to be a frostbite. The diagnosis can be made immediately by the patient history and examination. Acute thrombosis can also be considered, but is less likely when considering the history and extended cold exposure. A frostbite can be defined as a damage to the tissue as a result of sustained exposure to low environmental temperatures. Ice crystal form in the extracellular space, resulting in osmotic gradient, cellular dehydration, and electrolyte imbalance. In addition, direct injury to the endothelial cells can result in thrombus formation as well. The combination of cellular dehydration, vasoconstriction, and thrombus formation may result in severe peripheral vascular collapse and ischemia. Prior to it, note that rewarming may also result in further damage of the tissues. As a crystal melts down, the osmotic gradient reverses and the cell swells. If incomplete rewarming occurs, a cycle of alternating freezing and warming may cause even greater damage to the tissues. In addition, metabolites of arachidonic acid has been shown to increase after frostbite injuries and may contribute to vasoconstriction. There are multiple factors influencing the severity of injury and the eventual outcome. The most important factor is the degree of cold penetration to the soft tissue and the duration of exposure. Additional factors that promote heat loss are immobility, hyperventilation, inadequate protective clothing, contact with moisture or bare metal, or a wind chill effect. Host factors include alcohol, age, mental illness, compromised peripheral vasculature, and infection. Angiography has been used clinically to help determine the extent of vascular constriction and tissue ischemia from cold injuries. During the healing phase, angiography can provide further information on new collateral formation at the affected region. A triple phase bone scanning has been found to correlate directly with the final extent of tissue damage and may help in early as 48 hours. An MRI or MRA, magnetic resonance images, has been also used to assess vascular occlusion and degree of tissue ischemia with reasonable success. Non-surgical treatment. The management of soft bite is started immediately upon presentation. After stabilizing the patient's general condition, emphasis is given to regulate body temperature through air circulation and body warmers and warm liquid administration, both orally and parenterally. The affected area is rapidly rewarmed in circulating warm water, 40 to 44 degrees centigrade, for 15 to 30 minutes. The process may be quite painful and require parenteral analgesics. Regional anesthesia and anesthesia can be considered if severe pain is encountered. Multiple studies have confirmed the benefit of rapid rewarming versus slow rewarming. Surface blisters appear in the first 24 to 48 hours, and evidence suggests that they contain metabolites of arecanodic acid, which may potentiate progressive dermal ischemia. Topical application of aloe vera to the intact blisters is recommended because aloe vera is a tropical thromboxane inhibitor and may combat its vasoconstricting effect. Aspiration of the blister is another way to lessen the ischemic effect. Ruptured blisters are treated with 1% sulfadiazine. Systemic antibiotics are used if infection is apparent. Tetanus prophylaxis is administered according to usual guidelines. Ibuprofen is also administered to inhibit the effect of arecanodic acid metabolites and has been shown to decrease the amount of tissue ischemia and necrosis. A stentage with custom-made orthosis may be helpful in patients who exhibit contractures. If you try to conclude the management of acute cold injury to the hand, number 1, stabilize the patient. Number 2, systemic rewarming with warm environment and warm fluid resuscitation. Rewarming of the extremity with circulating warm water for 15 to 30 minutes. Number 4, tetanus prophylaxis. Number 5, analgesia or sedatives. Number 6, elevation of the arm and extremity. Number 7, application of aloe vera on intact blisters and silver sulfadiazine on ruptured blisters, and consideration of blister aspiration. Number 8, NSAIDs. Number 9, early immobilization followed by early range of motion exercises. Number 10, consideration of axillary block to provide sympathectomy and pain control. And number 11, antibiotics only if infection is present. Surgical treatment. An absolute indication for early surgical intervention are of infection and or ischiorectomy if viability is compromised secondary to ESHAR. A mid-lateral incisions of the digit allow for decompression and may heal by secondary intention. Traditionally, surgical intervention for the digital frostbite had parallel treatment of ischemic digits, that is, allowing for clear demarcation of non-viable tissue prior to amputation, maximize retention of viable tissue, and minimize possible need for revision amputation or possible infection if necrotic tissue is retained. In our case situation, an angiogram has shown that there is no blood supply distal to the wrist. Therefore, amputation was considered.